Welcome in, everyone. This is incredible. I'm so excited to be here with you all and go over some really high yield vignettes and content. So as you guys know, if you are studying for your step one or you're going through your didactic years, M1 and M2, the foundations of pathology and immunology are essential across all the systems you're going to be studying. And you've probably heard about Pathoma and Dr. Sitar, which he's incredible, and that book is definitely a staple resource. But what I found was when I was going through step one, you had Pathoma, you had first aid, you had all the video resources, and there wasn't really a resource that packaged all of these disciplines together, particularly chapters of 1 to 3 of Pathoma, and then the immunology portions of first aid. And so that's exactly what I did with my principles of pathology and immunology. And so I hope today you guys just get a little bit of a glimpse into how I've arranged the content to better your learning and understanding of these very foundational processes. So we will have my team just admit some more people as they come in, but for the purpose of time, we're going to crack on and get started. So I just wanted to preview and let you guys know that the MedSchoolBro team just launched a private advising program. And we not only help support students get into medical school, but we also have residents and doctors, specifically USMLE Step 1 and Step 2 tutors, who have gotten 270 plus on USMLE Step 2, who have, of course, tutored the USMLE Step 1 for many years. And they're using the principles of my guides to really teach and tutor you through these concepts. And so if you need any support in your USMLE journey, feel free to scan this QR code or save this for later. And you can actually book a free 15-minute call with one of our tutors. We have 2 tutors at the moment, as you can see here alongside myself, Fahad and Khalid, who are both a dermatology resident and ophthalmology resident in Miami. And so definitely check out our private advising, and we'll have more information to come at the end of this presentation. And stay tuned for a giveaway of my Path Immuno Guide. Anyone who does sign up with that QR code will also get the Path Immuno Guide for free to their email. So without further ado, let's crack on and talk about what we're going to be covering today. So as you can see here, we're going to be starting off with cellular adaptation, free radicals, apoptosis, the complement system, acute inflammation, thymus, vaccines, cancer tumorigenesis, and HIV. All right, so it's a packed session today. I want you all active, engaged. I want all of you putting your answers in the chat box. We're also going to be doing some active recall, so stay active, stay engaged. Let's do this. The QR code will be up a couple more times in this presentation, Don, so don't worry. I'll get that up for you guys. Starting off with cellular adaptation. Guys, this is just the foundation of how cells respond to stress, okay? So we have a vignette here. We have a 45-year-old man presenting to the clinic with complaint of difficulty swallowing. He has a 20-year history of smoking and chronic alcohol use. A biopsy of his esophageal mucosa shows replacement of the normal squamous epithelium with columnar epithelium, resembling that of the intestinal lining. Which of the following best describes this process, everyone? Answers in your chat. Everyone is putting D, and if you are saying D, metaplasia, you're absolutely correct. And one step further, what is this process? What pathological sequence are we talking about here? Barrett's esophagus. A very, very classic example of this metaplasia, right? You have your columnar epithelium converting and replacing to that squamous epithelium. Very, very good. So guys, let's start off simple and basic, because that's what Pathoma chapters 1 to 3 really show. So we have a normal cell, and a normal cell can respond in many different ways. One way it can respond is that it can increase in cell number. And what is that called? That is called our hyperplasia, right? We have increased stress, we have increased number, okay? Often going to be common in our labile and stable cell populations. And a classic example for the USMLE is your thyroid goiter in response to iodine deficiency. Reminder, guys, iodine is a key uptaken nutrient, right? Responsible for our iodine and thyroid hormone synthesis. Recall in my endo guide the principles of thyroglobulin and MIT-DIT coupling, right? Iodine is a key mediator in that. So what does the thyroid do to compensate, to respond to this? It's going to hyperplasia. It's going to increase in cell number because it's saying there's no thyroid hormone here. We need to increase more. We need more cells to do this. Let's increase the cell number, okay? Now, hyperplasia can also progress to what we call dysplasia, right, which is a pathological sequence. And a classic example is going to be your endometrial hyperplasia. So look out for unopposed estrogen, right? And what is protective against unopposed estrogen? Progesterone, okay? So these are just some principles we want to tie in here. Now, there is one key disease process, okay, that is a form of hyperplasia that does not progress to dysplasia. Does anyone know that example? It's common in older males. Exactly. If you said BPH, you're absolutely correct. Remember that that occurs in your transitional zone, right, which surrounds the urethra. And so you're going to look out for your urinary symptoms and incontinence, okay, versus your prostatic adenocarcinoma, peripheral zone. Remember, prostatic, peripheral, look for elevated PSA, okay? Very, very good, everyone. Now, we can also have an increase in cell size, which is hypertrophy, right? As you can see here, the cells are larger. This occurs in permanent cell populations, including your cardiac skeletal muscles and your neurons. Classic example, right ventricular hypertrophy in response to pulmonary hypertension. I also wanted to bring a point up that hyperplasia and hypertrophy can often occur alongside one another. And a classic example of this is in your uterus during pregnancy. Your uterus undergoes both hyperplasia and hypertrophy, so keep that in mind. We also can have a decrease in size and or number. And you might know that this is atrophy. And atrophy, as we mentioned, is going to be decreased hormonal stimulation, disuse, decreased nutrients or supply. Classic example is your carpal tunnel syndrome, where you get atrophy of your thenar muscles. And there's two key processes by which you can decrease your cell size. And that is A, through your ubiquitin proteasome process. Reminder that your intermediate filaments, guys, are going to be tagged by this ubiquitin, and then proteasomes are going to come along and remove that molecule, versus autophagy. Reminder, these are your autophagic vacuoles that are going to fuse with your lysosomes. They're going to secrete all those great hydrolytic enzymes to break down the cell, okay? So these are the two processes that occur to decrease in cell size. Now, we can also get this reversible cell differentiation, which ties us back to our vignette of Barrett's esophagus, right? And that is our metaplasia, okay? This is a change in cell type. We saw our columnar epithelium to our squamous in the case of Barrett's, as we see here. And guys, this is reversible. So if you remove the stressor, we can go back to a normal cell. But if you have a persistent stressor, this can actually transform to abnormal cell differentiation to a pathological process of dysplasia, okay? This is disordered cell growth. This is often precancerous. Now, this is still reversible, guys, in its early stages. But if we break past the basement membrane and get all of the features of carcinogenesis, then we can progress to a carcinoma, which is irreversible. Okay, everyone? Now, I also want to do a quick factoid, a high yield thing here. What is a form of what is a form, guys, of metaplasia that cannot transform to dysplasia? What is a form of metaplasia that does not transform to dysplasia? There's one key example, hint, it is in the breasts. Does anyone know in the chat? Very, very good, Carolina. Yes, if you said apocrine metaplasia of the breast, you're absolutely correct. And one more thing, guys, what vitamin deficiency can classically result in metaplasia? Martina, you absolutely correct. Vitamin A, you get your keratomalacia, guys. Look for clouding, drying of the cornea. Very, very good, everyone. Okay. Now, one last thing, which is not on the slide, but I wanted to bring it up, is your aplasia. Aplasia means no formation, right? This occurs during your embryogenesis. A classic example of your aplasia, guys, to know is your unilateral renal agenesis, which is often asymptomatic because the other kidney can compensate. But reminder, guys, also remember your embryology for step one, right? The ureteric bud doesn't develop, so you don't get differentiation of that metanephric blastoma, okay? Very, very good, everyone. Again, these foundations are going to apply to all different questions. All right, let's move on to free radicals and immunodeficiencies. So we have a 7-year-old boy with a history of recurrent bacterial and fungal infections. He's brought to the ED in distress. Physical exam reveals an ill-appearing patient with multiple purulent abscesses. Temperature is 101.6, so this is febrile. Blood cultures are drawn and the patient is given systemic antibiotic and antifungal therapy. Cultures ultimately grow Staph aureus and Candida albicans. Which of the following enzymes is most likely defective in this patient? Everyone answers in the chat box. Excellent. If you are saying D, you're absolutely correct. Let's just go through the other ones here. So in this vignette, guys, you're seeing recurrent infections that should already trigger you to think of some sort of primary immunodeficiency, especially in a 7-year-old. Okay. Physical exam is showing an active infection, right, with this temperature. And then also you want to look at the cultures. They grow both Staph aureus, so a bacteria, and a fungal, a Candida albicans, and that's going to give you a bit of a key into what enzyme is most likely defective. Again, guys, you're thinking here your respiratory burst pathway. You're probably thinking what disease? Very, very good, Eric and Ori. Chronic granulomatous disease. Let's crack on and talk about this really important respiratory burst pathway. So the goal of the respiratory burst pathway is to generate our free radicals, because these reactive oxygen species are really good at killing the bacteria. Now, in normal cases, NADPH oxidase is going to be found on our membranes of our phagocytes, right? Like our neutrophils and monocytes. They're going to be converted to this superoxide anion, okay? So it utilizes O2, transfers electrons, and creates this superanide oxide, okay? Then we have superoxide dismutase, and that is going to convert it to our hydrogen peroxide. Now, at hydrogen peroxide, we kind of have a couple different pathways we can go down. We can have myeloperoxidase, right, which can convert this to hyperchlorous acid. This is going to be really key in killing some fungal infections like Candida. But you can also have catalase here, which neutralizes the hydrogen peroxide into water. And then finally, you can have your iron and copper, right, in your Fenton reaction, and you can create this hydroxyl radical, which is your key killer in the reactive oxygen pathway. So let's now tie it into CJD, right, our chronic granulomatous disease. So what did we say this is? A defect in our NADPH oxidase. So we can't create this superoxide anion. Now, typically, guys, patients with CJD can actually use foreign hydrogen peroxide to generate their own reaction oxygen species. But the problem, guys, is catalase positive organisms like Staph aureus and Candida, which we saw in this vignette, can neutralize, right, their own H2O2, leaving these phagocytes without a means of killing these organisms. So CJD, excellent, important to know, guys, excellent deficiency in NADPH oxidase. As we mentioned, we have a defective ROS production, decreased respiratory burst. You need to know the catalase positive organisms. This can be tested in any shape or form. And I have a really good mnemonic, guys, right, from my book, and that is SPACE. SPACE not only helps me think of the granuloma, right, chronic granulomatous disease, but it also helps me remember the organisms. We talked about Staph aureus and Serratia, Pseudomonas, Aspergillosis, Candida, and Enterobacter. These are the key ones that are likely to be tested. Drill these into your memory. Space, space, space. Okay. Key diagnostic tests for CJD are going to be your DHR test. If there's no shift in color, that's going to be positive for CJD because we're deficient in this enzyme. We can also use the nitro blue test. If it stays yellow or colorless, fails to turn blue, as positive CJD. Okay. Now, another key tie-in that was in the vignette was myeloperoxidase, right, in blue here. And the issue with myeloperoxidase is if you have a deficiency, you can't create this hypochlorous acid. This hypochlorous acid is actually very important in killing Candida in particular. So if you see a vignette where they just mention Candida, then clue into perhaps a myeloperoxidase deficiency, okay? Because these can still kill the catalase positive organisms, but they have trouble killing your Candida. And I also just wanted to bring in a key point here and mention that free radical production, guys, and NADPH oxidase that you can see here is just one example. And so I always want you guys to remember that there's both physiological and pathological production of these free radicals. Think of your physiologial, right, your cytochrome C and your electron transport chain, right, transferring electrons via oxidative phosphorylation to oxygen, right? So that's a physiological free radical production. Versus pathological, we've talked about this one here with our ionizing radiation. We have hydroxy radical production. We have metals like Fenton reaction. Look out for your hemochromatosis. Look out for drugs that interfere with CYP450, like acetaminophen overdose. Look for chemicals and bleach products, right? So always clue in all the other topics as you're going through your study. It will really help tie in all these principles, okay? And a key factoid that came up on my NBME forums, probably you've seen it, myeloid peroxidase deficiency. Specifically, this myeloid peroxidase, guys, contains a blue-green heme-containing pigment that gives sputum its color. Random factoid. That's what you guys need to know about it. Okay. Now let's do something fun here and do a little illness script active recall. Here's an illness script. I want you to tell me the most likely immunodeficiency. Okay. Recurrent bacterial, viral, fungal, and protozoal infections plus lymphopenia. What are you guys thinking here? Hint: severe. If you said SCID, you're absolutely correct. And of course, in my pathology immunology guide, I have the best ways to remember this stuff. Remember, there's two deficiencies or two kind of processes that you need to know that can cause SCID. And I remember the ID at the end of it. A reminder that severe combined is going to help you remember that it's a B and T deficiency. So you're going to get both humoral and cell-mediated effects. The ID helps you remember an IL-2 receptor defect. Remember, your interleukins, guys, are very key. Make sure you know all the high-yield ones. Remember, hot T-bone steak is a great mnemonic. Hot for IL-1 fever. T for T cells, IL-2. And then steak, right? EAK for your IL-3 B cells, IL-4, IgE, and etc. Okay, guys? And then IL-6 is your acute phase reactants. So really, really high yield, guys, to know your interleukins, particularly IL-2 receptor defect for SCID. That's going to prevent T cell maturation. And then another cause is your adenosine deaminase deficiency, right? Because this is necessary to actually deaminate adenosine. And if you don't deaminate adenosine, this is a toxic, very toxic to your cells, builds up, and it prevents proper neutrophil and T cell killing. Okay, guys? Features, we've mentioned severe recurrent infections, and look out for other features that may be in the stem, such as failure to thrive, chronic diarrhea, and thrush based on the fungal infections. Okay, guys? Recurrent bacterial infections onset after 6 months. Key words here: after 6 months. Everyone in the chat. Everyone in the chat. If you say X-linked agammaglobulinemia, that's a mouthful. You are absolutely correct. Also known as Bruton's, because, guys, this is a BTK gene mutation in our tyrosine kinase. Remember all your Bs. X-linked recessive for boys. No B cell maturation. Recurrent bacterial infections, particularly what? Giardia, enterovirus, and lymphoid barely present because you don't get B cell maturation. Guys, the key thing to know here is onset after 6 months. Why? Because the maternal antibodies wean after 6 months. Remember, IgG, Gugu-Gaga crosses the placenta. That's everything for Bruton's. Very good, everyone. Now, to contrast, if we have recurrent bacterial infections, adult onset, what are you guys thinking? Very good, Ashley Hawley. Absolutely correct. If you are saying combined variable immunodeficiency, this is a milder form. Look for post-pubertal presentation of recurrent bacterial infections, often less severe. And finally, skin, lung infections, eczema, elevated IgE. What are you thinking? No, close. Yes, yes, Algly. Yes, yes, hyper IgE. Yes. So if you're saying job syndrome, which a few of you are, you're absolutely correct. And a way to remember this is to learn your A, B, C, D, E, Fs to get a job. Abscesses, baby teeth, coarse facies, dermatological problems, and increased IgE. Job syndrome is also often known as hyper IgE syndrome. Absolutely correct if you said that. So again, all my funny mnemonics and fun memory tricks here to remember these key principles of your immunodeficiencies. And look, guys, at the vignettes and the illness vignette scripts of the STEM to isolate these key patterns, okay? We are now moving on to apoptosis. We have a vignette. 32-year-old woman undergoes a biopsy of suspicious breast mass. Histological examination reveals cells with features of apoptosis, including cell shrinkage, chromatin condensation, and membrane blooding. The intrinsic pathway of the apoptosis is implicated in this process. Which of the following proteins is most directly responsible for the release of cytochrome C from the mitochondrial during apoptosis? Everyone in the chat box, put in your answers. There's no wrong answers today. It's a bit of a factoid question, but guys, the USMLE love and your NBME forms love factoidy questions from your principles of pathology and immunology. So you still need to know this stuff. Okay, we are getting various answers. So this will be a good one to go over. If you are saying D, facts, you're absolutely correct. We'll go over these in the next slide, but quick rapid recall here. BCL2 is anti-apoptotic. That's going to prevent cytochrome C. BAX and BAC are going to be pro-apoptotic. They're going to release cytochrome C, okay? So we're going to go over this in fun memory tricks so you never forget this on the next slide, but just active recall. Capsase is going to be downstream of this process. P53 is a tumor suppressor. APAF, I honestly have no idea. Apoptosis. So apoptosis, I want you to remember APOP for a programmed process because we're going to always contrast apoptosis with necrosis, right? Apoptosis can be both physiologic and pathologic versus necrosis is always pathological. This is going to be energy, ATP-dependent programmed cell death. These are going to ultimately lead to capsase activation, which is going to cause what you saw in the vignette of cell breakdown and shrinkage, chromatin condensation, and formation of apoptotic bodies to be phagocytosed. Reminder, guys, cell membranes remain intact here, and look out for this DNA laddering of 180 BP as an indicator for apoptosis. Now, there's two key processes of apoptosis that you need to know for the USMLE. The first is your intrinsic mitochondrial pathway. Okay, so cell injury, DNA damage, decreased hormonal stimulation. Think of intrinsic, okay, internal stress. Okay, this is going to inactivate BCL2. And we talked about how the mitochondrial membrane and release of cytochrome C is going to be the key player here in activating our capsases, whether we activate or inhibit. Now, our pro-apoptotic, so the ones that are going to increase release of cytochrome C and subsequently activate capsases, are going to be BAC and BACs, which we saw in the vignette. Okay, you can remember that BACs and BAC are bad for survival. They increase cytochrome C, increase cell death. They're bad for survival. Very easy way to remember that. To contrast, anti-apoptotic is going to be your BCL2, BCLXL. And I remember the BCL, BRC, right? BCL here for broccoli makes you live longer. Fun little trick, guys. Use it if you'd like, but really easy to remember that BAC and BACs are bad for survival, but BCL2 is going to inhibit this process. And guys, does anyone know a particular lymphoma that is caused based on BCL2 activity? If you're saying follicular lymphoma, you're absolutely correct. We get BCL2 overexpression. If you overexpress BCL2, you're not, right? You're not going to apoptose the cell. You're going to get increased proliferation of this lymphoma, okay? And particularly, this is going to be your translocation 1418, okay? Also important to know these for the USMLE Step 1. To contrast, everyone, we have our extrinsic pathway, our death receptor pathway. I want you to think of external signals like your fast ligand and your TNF alpha. Okay, this is going to be implicating in immune cell regulation and cytotoxic T cells. So we have one pathway, right, where we talked about our fast ligand binding FAS. It's going to initiate the capsases and cell death. On the other hand, our cytotoxic T cells, right, our CD8 cells, they're going to release perforin and granzyme B, which activate our capsases. Okay, so really important, guys, to know the difference between these two and any types of questions they could ask. Now, it's a bit of a tough question, everyone. What condition is caused by defective FAS ligand interaction? This is a bit of a factoid, less high yield. But if you guys, oh yeah, very, very good, Anna. Autoimmune lymphoproliferative syndrome, you're going to get this lymphadenopathy, hepatosplenomegaly, and autoimmune cytopenias. Very, very good. You guys are doing excellent in the chat. Stay active, stay engaged, and we're going to move on to the complement system. We have a vignette. 25-year-old woman presents with a history of multiple severe infections. She reports recurrent episodes of fever, fatigue, and joint pain, with several documented cases of bacteremia. Lab tests reveal normal levels of complement components C1, C2, and C4, but the CH50 assay shows a significantly reduced complement activity and a terminal complement component assay C5, C9, low levels of C5. I already see you guys in the chat. Which of the following types of infections is the most at risk for her due to the complement deficiency? If you're saying D, you're absolutely correct with your Neisseria meningitis. Okay, we have a vignette here, right? Recurrent infection we have a complement deficiency. We have particularly a terminal complement deficiency, right, of C5 to C9. And so you guys are keying in to your Neisseria, meningitis formation, failure or formation of your MAC complex. Very, very good. Just active recall here, strep pneumo. Remember, that's an encapsulated organism, so look out for asplenia and those types of things. Candida, we talked about fungal, right? So look out for immunocompromised or T-cell defects. Staph aureus, we talked about as a catalase positive organism, so might be related to a CJD vignette. And then mycobacterium tuberculosis, look for cell-mediated immunodeficiencies like your HIV. Okay, so we have our complement system. Again, this is probably one of my favorite slides and one of my favorite sections of my pathology immunology guide because the memory tricks are just gold. Okay, so we have three main pathways that activate complement. Okay, we have our classical pathway, and remember that GM makes classic cars because C1, okay, our complement protein 1 is actually going to bind IgG and IgM. It's going to activate those. Our alternative pathway, okay, reminder that's going to be spontaneous hydrolysis of our C3, right? And these are going to be on the surface of our bacteria or endotoxins. And it's going to activate C3b, our opsonizing agent. And then finally, our mannose lectin pathway. Guys, remember these mannose binding lectins, which are going to be on our microbes. Ultimately, all of these are going to converge, though, to activate C3 convertase, which is going to convert C3 to C3a and b. From here, C5 convertase is going to convert C3b to C5. And then from here, C5 is going to join with C5a plus C5b. And that's going to then form our terminal membrane attack complex with C5b and C6 to C9, which we saw in the vignette. Now here, our lovely mnemonics, C3a and C5a are amphylactoxins. These are going to trigger mast cell degranulation. So your green A's here, remember your A's for that. Also a reminder that C5a is chemotactic, so it's going to attract neutrophils to the site. This is alongside our interleukin 8 and our leukotriene B4. A great way to remember C3b is that it binds LPS on bacteria, binds bacteria. This is one of our opsonizing complement proteins. And then finally, we have our MAC, which is our end of the complement system, and that is our lysing agent. It's going to create a hole in the membrane and kill off the organisms. Now, in particular, guys, it's important to understand how they might test this as it relates to some deficiencies. If we have an early complement deficiency, right, we are going to have an increased risk of pyogenic sinopulmonary infections because why? C3b is responsible for clearing, right, bacterial complexes. And in particular, it helps clear our antigen antibody complexes in our autoimmune processes like SLE. So you can think of SL early to remember that SLE increased risk in early complement deficiency. But tying it back to our vignette here, guys, terminal complement deficiency of C5 to C9, as we see here, we don't get a MAC complex formed. A MAC complex formed. Our MAC is essential in killing off Neisseria infections in particular, which is the answer to the vignette. And you can remember this, guys. I love eating nice big Macs from 5 to 9 p.m. Okay, just a fun memory trick to remember that. And then doing a little heme-onc tie-in here, because again, guys, my guides, what I try to do here is I like to bring up topics as they relate to the processes, the physiology that we're talking about. So instead of learning paroxysmal nocturnal hemoglobinuria like in its own random section in heme-onc, well, let's understand that it's a defect in the PIGA gene, which prevents formation of these anchors, right, to our cells, and we can't get protection against complement. So complement inhibitors, essentially, right, are not present on our RBCs, and so they just get lysed. They get wiped out essentially by complement, and that's why we get this pancytopenia, venous thrombosis, and hemolytic anemia. Now, guys, really important to understand a monoclonal antibody that can be used for PNH. And does anyone know what that monoclonal antibody is? Eculizumab. If you said eculizumab, very good, Chun. You're absolutely correct. And that's an antibody to the C5 protein. And I remember it, guys, because E is the fifth letter. Okay, so E is the fifth letter. Eculizumab is going to be an antibody to C5. Very, very good. And finally, what immunoglobulin alongside C3b is going to be an opsonizing agent, guys? Which immunoglobulin is an opsonizing agent? You'll active recall in the chat. IgG. Very, very good. So I hope this slide just paints a good picture for you, both the functions of these complement proteins as well as some of the key deficiencies that you may see on test day. Okay. All right. So we are back to this slide, and I know a couple of you asked about it. This is the QR code to schedule a free 15-minute consultation with one of our advisors. Now, if you need help with planning out your step 1 schedule or step 2 schedule, if you need help with residency applications, if you need help with med school applications, if you need help with shelf exams, anything and in between, we are here to support you. If you do book a 15-minute call, free 15-minute call using the QR, you're going to automatically get this Principles of Pathology and Immunology guide that I've taken a lot of the concepts from today. Okay, so if you guys book a call with one of our advisors, we'll send along this PDF complementary to that. And really, guys, we are here to support you in whatever way you need. So if that's, how to, as mentioned, study for the USMLE or USMLE Step 2, if that's specific tutoring on some of these topics, we are here to support you. As I've mentioned, we have a really, really strong team in our MedSchoolBro team of Fahad, Khalid, and a surrounding group. So book that call if you guys need support, and stay tuned, because at the end, we're also going to be doing a fun giveaway for this guide. All right. Quick, how's everyone doing? Just a quick break here. This is about halfway through. How's everyone doing in the chat? Great. Are you guys liking the questions, the integration, the fun tricks? Yeah. I'm so glad. I'm so glad. Okay. Well, let's crack on. Halfway through. Yeah, guys, this is going to be probably another 30 minutes. Yep. I'm so happy you guys are so active. You guys are so great with this content. Yes. Yeah. We will send you the recording of this as well. Yeah. Thank you, Caroline. I appreciate that. Thank you, Alma. Okay. Let's crack on and talk about acute inflammation. Reminder, neutrophils are going to be your key mediator here. And let's talk about a vignette. We have a 6-year-old boy who's presenting with recurrent infections, including respiratory and skin infections, along with neurological symptoms such as ataxia and peripheral neuropathy. On physical exam, he has hypopigmented skin and hair. Lab studies reveal peripheral blood smear findings of large granules within white blood cells. Which of the following best describes the underlying process responsible for this patient's condition? Everyone in the chat box. If you're saying C, you're absolutely correct. Impairment in microtubule function affecting lysosome formation. Does anyone want to throw out what this disease process is called? Chidiac-Higashi syndrome. Very, very good. Again, let's just do a quick active recall here. Deficiency in NADPH oxidase is our CJD, chronic granulomatous disease. Dysfunction of CD18 integrin is your leukocyte adhesion deficiency, which we'll talk about. This is Chidiac-Higashi. We've talked about myeloid peroxidase, and there we go. So, very, very, guys, important to understand our neutrophil arriving and function. So, it's a 6-step process, as you can see illustrated beautifully here, starting off with our margination. Reminder, guys, in response to this acute inflammation, blood cells are going to vasodilate, right? And these cells are going to come from the center of the vessel lumen to the periphery. And really, in this rolling step, guys, we're going to get an upregulation of what we call these selectins, E-selectin and P-selectin. You can think of these selectins almost as speed bumps on the endothelial surface of your blood cell, right? So these neutrophils are tumbling down, and they hit these little speed bumps and slow down, okay? That's the second step. Then we have adhesion. And adhesion is going to be through these molecules such as ICAM and VCAM1 that you can see expressed here. They're going to be upregulated by TNF-alpha and IL-1, right, which are going to be important in our acute inflammation. And so, guys, I wanted to bring up adhesion here because there's a very key tie-in, and that is our leukocyte adhesion deficiency. And reminder that we have 2 types. In type 1, it's an autorecessive defect in our CD18 integrin. This causes impaired leukocyte migration and adhesion to the endothelium. And my MedSchoolBro mnemonic, LAD, I want you to remember L for late separation of umbilical cord, A for absent pus, you get recurrent infections, and B for dysfunctional neutrophils. You get an increased amount in the blood because they fail to adhere and they fail to transmigrate. That's going to take us to number 4, which is our transmigration. A key player here is our PCAM1 in helping our leukocytes migrate across the endothelial barrier. And remember, guys, our neutrophil chemoattractants, right? C5a, IL-8, leukotriene B4. I'm repeating this because we need to drill this in. I don't know how many factoids from these chapters that I got, honestly, on my USMLE. So that's why I'm really trying to drill these in. I believe I got an IL-8 question with the neutrophil chemoattractant. So that's why I'm bringing it up this many times. Then, guys, we have step number 5, which is going to tie into the vignette we just talked about, and that's going to be our phagocytosis. And that's going to be the engulfing of our pathogens or necrotic tissue. And we've talked about, guys, again, our key opsonins are IgG, C3b. C3b binds bacteria. Good. And our tie-in here was Chidia-Kagashi. And Chidia-Kagashi is actually an autosomal defect in our lysosomal trafficking in our list gene. And so think about it, guys. The phagocyte cannot fuse with the lysosome. So we can't form these phagolysosomes. We can't form phagolysosomes. We can't engulf our pathogens. We get impaired killing in phagocytosis. And that's why we see the CNS defect, hemorrhage, decreased immunity, albinism in these coarse giant granules. Really key to understand that here in that image. Okay. And then finally, number 6 is killing. If we tie back to our first slide, guys, on free radicals, right, in our oxidative bursts, you're going to be thinking of your reaction to oxygen species and killing. Okay. I hope that tied everything in together. Again, what I love about my pathology and immunology guide and all of my step 1 guides is that I tie in the key pathological sequences where it makes sense. So instead of, guys, putting leukocyte adhesion deficiency or Chidia-Kagashi syndrome in just a random table of immunodeficiencies, right, where it's very hard to just memorize a list of 20 immunodeficiencies, well, why don't we integrate them where they're meant to be, you know, in terms of what defect and what processes they disrupt for adhesion, for phagocytosis, right? And so that's why my guide kind of integrates these disciplines to hopefully better your understanding of how this all connects. Okay. And I wanted to just add a fun little memory trick that I found helpful for Weevil-Palade bodies. And I remember the W for von Willebrand factor. Remember, that's a key mediator in your primary hemostasis. And the P for P-selectin. What do we say P-selectins were? And E-selectin, those were our speed bumps in helping rolling. Okay. We are on to the thymus. Thymus for T cells. Good. A newborn is admitted to the neonatal intensive care unit with a history of recurrent infections. Physical exam is notable for a hollow systolic murmur at the left sternal border and distinct facial features, including a broad, flat nasal bridge and low set ears. Labs are notable for hypocalcemia. A chest x-ray reveals the absence of a specific structure that is crucial for immune system development. Given the clinical presentation and imaging findings, which of the following embryological structures is primarily responsible for the development of the absent structure? You guys are amazing. I see so many C's in the chat. If you're saying C, you are correct. And what process is this, guys? What disease process? Did George is so high yield for USMLE Step 1. Chun 22 Q11 microdeletion. I love it. I love it. So as you guys can orient yourselves, our T cell precursors and our maturation, right, our tolerance is all going to occur in the thymus. And it's important, guys, to understand that we have both positive selection that occurs in the cortex and negative selection in the medulla. And you have to think about our T cells and the production and maturation of these T cells with our autoimmunity, right? We want double positive CD4 8 cells that express TCRs capable of self-binding MHC. We want those. Those are positive. We want them to be able to recognize and bind self-MHC. Okay? So ones that can, the T cells that can bind self-MHC are going to be survived. That's good. Okay? Those that fail to recognize self-MHC are going to undergo apoptosis. What did we say about apoptosis, guys? There's physiologic and pathological causes. Well, this is a physiologic cause. We want some apoptosis in our body to do these things, right? In our negative selection in our medulla, right, this is T cells that are going to self-react to our self-antigens. We don't like this. This is not good. So we want to destroy the T cells that bind too strongly to self-antigens to prevent autoimmunity, right? And so after this positive selection, thymocytes that express self-antigens are going to be signed off and triggered for apoptosis, okay? So that's just a bit of immunology tie-in there. And now connecting to our vignette of DeGeorge syndrome and this sale sign, you're going to remember the MedSchoolBro mnemonic, 3T's of the thymus. Thymus arises from the third pharyngeal pouch and involutes by 3 years old. Very fun. This is the sale sign you'll see on X-ray there. Then, guys, with our DeGeorge syndrome, you're going to see this absent sale sign because why? We have defective, right? Atypical development of our third and fourth pharyngeal pouches. We get an absent thymus. We have an absent thymus. We have an absent sale sign. If we have an absent thymus, we have an absolute decrease in our T cell count, right? And that's going to make us more susceptible to viral and fungal infections. And guys, a lovely, lovely mnemonic for DeGeorge is catch 22. So remember this little DeGeorge guy down here, number 22. You're going to remember it for cardiac malformations like truncus arteriosus and TOF, abnormal facies, which we saw in the vignette, thymic hypoplasia, of course, with this sale sign, cleft palate. Reminder, guys, that your parathyroids, right, are also coming from your third and fourth pharyngeal pouches. And so you're going to get parathyroid hypoplasia. Remember, PTH is going to increase calcium levels. If we get parathyroid hypoplasia, you're going to have decrease. We're going to have hypocalcemia. And then, guys, finally, it's a 22 Q11 micro deletion. Very, very good. Let's move on to our next topic of vaccines. So we have a 30-year-old man involved in a motor vehicle accident sustaining multiple injuries, including a splenic hemorrhage. He undergoes an emergency splenectomy. In the postoperative period, he has an increased risk for infections due to the absence of the spleen. Which of the following vaccinations is most crucial? You guys are right on it. If you're saying A, pneumococcal, you are absolutely correct. Now, guys, what are our other encapsulated organisms? There's 3 high-yield ones. You can remember the mnemonic SHIN. We have strep pneumo, H influenza type B, and Neisseria. Very, very good, everyone. And so, guys, we're going to want to vaccinate splenic patients with those 3. So, guys, just a little bit of a tie into physiology here. Reminder that a spleen is a lymphoid organ, right? And it has 3 key components that you need to recognize. It has a red pulp, which is really the filtration system, right? This is going to clear out old RBCs, okay? It contains our sinusoids and those cords of Billroth. We have our marginal zone, which is really the spot between our red pulp and white pulp. And that's going to be for kind of acting as a physical barrier as well as containing our macrophages. And then our white pulp in specific is going to be the immune surveillance. It's going to contain these periarteriolar sheaths with our T cells and our follicles, which are our B cells, okay? And a tie into the vignette here is our marginal zone contains these splenic macrophages, and these splenic macrophages are key in killing these encapsulated organisms. And so you want to look out for vaccinations for these 3. Now, a reminder, though, guys, that we have other encapsulated organisms as well. And you can remember the MedSchoolBro mnemonic. Yes, some killer bacteria have pretty nice capsule for all of these. The stars indicate the vaccine preventable ones, which are strep pneumo of the answer, H influenza type B, and Neisseria meningitis. I also wanted to do an integration with vaccine types because that's also highly tested. Reminder, guys, that we have our subunit vaccines. Okay, these are our recombinant and conjugate vaccines. They essentially take part or a subunit of the pathogen and use those proteins or polysaccharide capsules. And I wanted to bring this tie-in because our strep pneumo, our pneumococcal vaccine, as you can see here, is actually going to be a subunit. So I could have also presented a vignette and asked what type of vaccine would we want to use. And if it was cluing into pneumococcal, then you could pick subunit, conjugate, polysaccharide capsule, all that, and in between you could be tested on. Okay, happy hippos have safe naps is a fun way to remember these ones. And in particular, they're going to decrease the risk of side effects because you're only using a part, right? A part of the pathogen. Reminder, guys, that your live attenuated vaccines, classically MMR, varicella, yellow fever, or oral polio, those are going to be long-standing and strong. But the problem is we can't give those in patients with immunocompromised, right? Think about long-standing corticosteroids and then also pregnancy. We can't give live attenuated in pregnancy or immunocompromised. Toxoid vaccines, guys, are going to be inactivated toxins produced by the pathogen. And I remember deputy, D for diphtheria, T for pertussis, and T for tetanus. For your inactivated, okay, these are going to use an inactivated part of the pathogen, which is going to cause a weaker response in compared to your live. And so these ones are actually going to be safe in immunocompromised. And you can remember the mnemonic RIP, ACE, rabies, influenza, polio, IPV, Epe, cholera, and encephalitis, your Japanese and tick-borne. Okay. Yes, Tdap is a toxoid vaccine. Yeah. So hope this integration was helpful. Again, make sure you know these encapsulated organisms, in particular, the ones starred for your vaccine prevention. Now we have section 8, cancer tumorigenesis. We have a 3-year-old boy brought into the pediatrician by his parents who are concerned about a white reflex in his right eye, which they noticed in photographs. The child also has decreased vision in the affected eye. On examination, there is an absent red reflex and a mass is visible on fundoscopic examination. Imaging confirms a retinal tumor. The patient is an increased risk for which of the following, everyone? Really, really good, guys. If you are saying osteosarcoma. So what we see here, guys, what is this called? White reflex in the right eye, leukocoria, absent red reflex. This is very suspicious for a retinoblastoma, a reminder of mutation in your RB1 tumor suppressor on chromosome 13, right? Breast cancer, what are you guys thinking about? That's more of a BRCA mutation, right? Look for family history of your breast and ovarian cancers. Wilms tumor, guys. Wilms tumor, reminder that that's going to be also known as your nephroblastoma. I want you to think of a unilateral mass, right? Abdominal mass, hematuria, hypertension. And guys, what exactly? Very good, Chin. I was going to ask, what syndromes can you see Wilms tumor in? There's 2. One is Wagner syndrome. WAGR stands for Wilms tumor, anhydria, genitourinary abnormalities, and retardation, so intellectual. And then the other thing, guys, to note is Beckwith-Weidman syndrome. Yes, very, very good, guys. Macroglossia, hyperplasia, hypoglycemia is key, guys, and your increased risk of your Wilms tumor. Contrast, guys, your Wilms tumor from your neuroblastoma. Neuroblastoma, guys, is going to have an abdominal mass that crosses the midline. You're going to look for elevated catecholamines, your homocyte rosettes, and your N-mic oncogene. Very, very good. Neurofibromatosis, guys, you're going to think your type 1 and type 2s, right? Your type 2 for bilateral schwannoma, and then your type 1 for your, Fayolay spots, neurofibromas, optic gliomas, all that good stuff. And then medulloblastoma, common pediatric cerebellar tumor. So you're going to look out for signs of cerebellar dysfunction like ataxia and other signs of increased ICP. Okay. Now, this is one of my favorite slides and one of my favorite concepts from the Path Immuno book. And that is cellular adaptation and talking about our oncogenes and our tumor suppressor genes. So guys, think of it as a tug of war, this cellular adaptation and cancer tumorigenesis. You have your gain of function oncogenes. Your oncogenes are going to cause progression of tumorigenesis. And then you have tumor suppressor genes, which is your break, is your stop. If you get a loss of your tumor suppressor genes or you get a gain of your oncogenes, right, this obviously is going to tilt to one side over the other and cause carcinogenesis. And so it's key, guys, to think back to this cell cycle and some of your basic principles of DNA replication. And reminder, guys, that our cell checkpoint tumor suppressor genes, our RB gene, our CDKN2A, and our TP53, our classic tumor suppressor, are going to work to block the transition from our G1 phase to our S, so our DNA replication phase. And tying back to the vignette, everyone, we have our RB gene, which you can think as RB as retina and bone for retinoblastoma and osteosarcoma. Remember, it's located on chromosome 13, inherited via autosomal dominant. We have our CDKN2A, which is going to be implicated specifically in melanoma, you need to know. And then our T53 is in most cancers. But in specific, I want you to hone in on this SBLA syndrome, sarcoma, breast, leukemia, and adrenal gland. Very good, Audie. You're beating me to it. Lee-Fraumeni syndrome, guys, very, very good, is also known as your SBLA syndrome. This is your autodominant. And females, guys, are going to have about 100% chance of progressing to breast cancer. Very, very, very good. Now, let's pivot to our gain of function oncogenes. And there's different subtypes. Our nuclear regulators are here. And a fun memory trick, guys, is your L-Mike mutation affect the lungs. L-Mike, which one is it going to affect here? In the chat box, L-Mike, what type of lung cancer? Small cell lung cancer, absolutely correct. And guys, also think about other ways they might test small cell lung cancer, right? This is a neuroendocrine tumor. So they might test the immunohistochemical stains like chromogranin A. Okay, keep those things in mind as well. And also keep in mind always your paraneoplastic syndromes, right? In particular for small cell lung cancer, they can be your SIDH, your Cushing's, your Lambert-Eaton. Very, very good, Audie. You are on it. Our N-Mike we talked about is going to lead to neuroblastoma. You can remember it that way. And what about our C-Mike, everyone? What is C-Mike implicated in? Burkitt's. Absolutely correct if you're saying Burkitt's lymphoma. Guys, this is a B-cell lymphoma associated with EBV. C-Mike, right, on chromosome 8, resulting in a what? A T8 to 14 translocation. What classic sign do you guys see on histology? Look up at night. Starry sky appearance. Yep, starry sky appearance. Very good. And reminder, guys, there's two forms. You have your endemic form, which is going to be sporadic. Sorry, you have your endemic and sporadic form. Endemic form is going to appear on the jaw, classically, or facial, and it's going to be related to your EBV. And then you have your sporadic form, which is going to occur on as an abdominal mass. Very, very good, Kevin. Now let's move on to growth factor receptors. HER2. What is HER2 implicated in? Affects HER2 breast carcinomas. Very good. And guys, what monoclonal antibody targets HER2? Trastuzumab. Don't you guys love all this integration? This is exactly how I want you guys learning and preparing for the USMLE Step 1. What about RET? RET, you guys are thinking about your MEN syndromes, multiple endocrine neoplasia, in particular your MEN2A, 2B medullary thyroid carcinoma. Active recall, guys, what are going to be MEN2A? 2M1P. It looks like, Chun, you've used my endocrine guide. I love it. Yes. Very, very good, guys. And your KIT is going to affect your cytokine receptor, and this is going to be implicated in your gastrointestinal stromal tumor. Okay. Our cell cycle regulators are CCND1, cyclin D1. I like to remember as the cycle of the Earth's mantle, because this is implicated in mantle cell lymphoma, which is a translocation of your 11 to 14. What cyclin D1 is going to do is it's going to essentially progress and activate G1 to S phase. Okay. And finally, we have our signal transducers. RAS is going to be implicated in various carcinoma, lymphomas, and melanomas. And then our BCR-ABL. What's the classic one here, guys? Yes, very, very good. CML. Classically, guys, your T9, 22 translocation on that Philadelphia chromosome. And guys, what is going to be the tyrosine kinase inhibitor? What is the name of the tyrosine kinase inhibitor we give? Imatinib. Yep, imatinib. Very, very good, everyone. Again, I love this slide. It has all my fun memory tricks. It builds in all those other things. Keep in mind how they might test, right? HER2 with trastuzumab, or your tyrosine kinase inhibitor like imatinib, or your lead for many syndrome. Very, very good. Guys, we have made it to the last section of this presentation and webinar. I hope you guys have enjoyed it thus far. We are going to be talking about HIV. We're going to be talking about how HIV affects the host cell and how the pharmacology ties in as well. So last vignette, stay active, stay ready. Let's get through this. We have a 45-year-old man with a recent diagnosis of HIV being under evaluation for potential new treatments. Pharmacology companies working on a novel drug designed to prevent the attachment of HIV to human entry cells, aiming to halt the initial step of viral entry. Which HIV protein should the drug target to effectively block this process? Really good work, everyone. If you're saying D, GP120 is the correct answer. Let's talk just about this. So we have our virus and we have our host cell. We're going to step by step go through exactly how the virus is going to essentially use the host cell machinery to replicate its new viruses. Okay. And we're also going to tie in the key antiretrovirals that are going to target each step of this process. Okay. So what did we talk about in the vignette? The initial attaching point here is going to be your GP120. Okay. In a particular, a drug that's going to combat the attachment phase is going to be your Mariviroc. Okay. In this early stage of entry, we have both attachment and penetration or fusion. And the fusion is going to be blocked by something called influvirtide. Very good. And in particular, right, this is going to target the GP41. So these little knobs here is GP41, and it helps fuse across this host cell membrane. And so what you're going to remember, guys, is the tide fuses with the rock to help you remember the entry fusion inhibitors. And flupirtide is going to help you remember that it binds GP41 because the F for 41. The tide and rock are going to help you remember that they're this class. And then Mariviroc in particular, guys, the answer to this question is going to bind CCR5, which is going to inhibit GP120. All right, so we've the viral envelope, right, with the host cell membrane essentially has fused, and our host cell has now entered, our virus has now entered the host cell. So the next step that's going to occur is reverse transcription. Okay, essentially, guys, what it's going to try to do is going to create this viral RNA and convert it to complementary DNA via reverse transcriptase. Okay, and the key things that are going to block, right, our viral RNA to our cDNA is going to be our reverse transcriptase inhibitors, and those are our NNRTIs and our NRTIs. Our NNRTIs will all have the suffix vir in the middle of their name, and that's the way I remember them. They're going to bind reverse transcriptase at a different site than our NRTIs. Remember the side effects of rash and hepatotoxicity for this class. Now, we also have our NRTIs, which I'll come back to the trick, but these are the rest of the naming conventions, and that's classically abacavir and tenofovir. Okay, these are going to competitively inhibit our nucleotide binding to reverse transcriptase, and classically, guys, you want to know about myelosuppression and nephrotoxicity. All right, so viral RNA has been converted to cDNA. Now our next step, guys, in the nucleus of the cell is integration. So integrase is going to be the key enzyme that takes the cDNA, transports it into the nucleus, right, where it can integrate into the host genome. Okay, and our integrase inhibitors, with a really easy suffix because it's right in the name, integrase inhibitors have tegra in their name, as you can see right here, like raltegravir. These are going to inhibit HIV genome integration. Pretty self-explanatory, right in the name. Classic things to look out for is increased creatine kinase and weight gain as side effects. All right, so we're now integrated into the host genome. Now we're in the host genome. Now we want to just carry out normal replication and transcription and translocation. So we want to create RNA and create protein, right? So transcription, translocation is going to occur, and we have one more step where we can combat the machinery of this virus, and that is the proteolytic processing aspect, okay? And as the name implies, our protease inhibitors are going to inhibit this proteolytic processing, okay? These all have the suffix navir, and I like to remember that pros never tease. Navir for never tease, like atazanavir is a classic example. They are going to prevent maturation of the new viruses, as you can see here, and the final steps of budding and release. Really, really key, guys, to know your protease inhibitors, hyperglycemia as a key side effect, okay? But I hope this helped not only help you understand the process in which HIV takes in terms of essentially taking over the host cell machinery, but also the tie-ins of pharmacology as they inhibit each step along this process. So guys, did you find this helpful? Do you guys find this helpful? Yeah? Amazing. It finally makes sense. I love to see that, Alex. Yep. And guys, again, everything from this presentation is right from my new pathology and immunology guide. So it's all here. All the content is here, plus lots more, of course. I just wanted to bring up this slide again to show you that we are booking free 15-minute consultations for you guys if you need support in your step 1 or step 2 journey. If you guys need support in residency applications, in securing electives, anything of that sort, feel free to book a call with one of our advisors. If you do book a call, you'll also get this digital PDF and Anki deck when you sign up for advising. Okay. So thank you guys so much. I hope you loved this. If you guys are also interested in my pathology and immunology guide, you can head over to MedSchoolBro.com and grab your copy today. Again, you can book a call. If you guys do sign up with our private advising, you guys will get the guide for free as well. I loved having all of you guys join me. Good luck to all of you as you study for this exam. A reminder that I have books in cardiology, endocrinology, gastroenterology, MSK Derm, and more to come as well. So hope you guys enjoyed this. You guys are doing great. Really, really appreciate all your support always. As always, guys, study smarter, not harder with these books.